Dr. Marina, are you ready? Can you hear us?
Yes, doctor, I can hear
Marina
you.
Adel is Administrative Pathology, South Egypt Cancer Institute, and she is presenting to us, although different, could set together. Please start sharing your screen, Doctor.
Okay, Dr. Mahmoud. Is the
Okay, Doctor, I
screen
can see your
okay?
screen.
Yeah.
Start the slideshow.
Okay, Dr. Muhammad. Good afternoon. Happy International Day of Pathology. I am Marina Adel, Administrator of Pathology, South Egypt Cancer Institute, Egypt. I'm really honored to participate for my first time in these valuable events. I'm going to introduce a presenting case titled Although Different Can Be Said Together, supervised by Dr. Marwa Hussein Tamam, Associated Professor of Pathology, South Egypt Cancer Institute. Let's start with the clinical history. A 60-year-old man referred to the surgical oncology clinic at South Egypt Cancer Institute for right gluteal mass. The condition started 1 year ago with a progressive course. Radiological findings. MRI revealed non-circumscribed irregular outline superficial soft tissue mass, seen at lateral aspect of right gluteal region, measuring about 13 by 6 by 7 cm. No definite infiltration of gluteal muscles, with normal bone marrow of bony pelvis. This is associated with multiple malignant featuring right inguinal lymph nodes, largest measured about 4 by 3 by 1 cm. PET scan was free and showed no other masses all over the body. True cat needle biopsy was done, diagnosed as squamous cell carcinoma. Then, wide local excision was performed. The gross picture was 20 by 13 cm part of skin and subcutaneous tissue that showed fungating ulcerative ill-defined mass, measured 19 by 12 by 5 cm, with grayish-white heterogeneous cut section, similar to this picture. Now, microscopic picture. Our microscopic picture showed first in situ component of epidermis in form of full-thickness keratinocyte atypia, marked by blue arrow. Downward growth below level of overlying epidermis, formed of nests and groups of malignant keratinocytes, marked by pink arrow. Another slide here. We can see here nests with keratin pearls and hyperchromatic pleomorphic nuclei cells, neoplastic cells with hyperchromatic pleomorphic nuclei, and inconspicuous nucleoli. And intracellular keratin could be seen in the neoplastic cells. By immunohistochemistry, P63 was nuclear positive. So, what is the problem? It is just a cutaneous moderately differentiated squamous cell carcinoma. Of course, you will be right if those are the only H&E slides. Now let's take just a few seconds break from pathology and check your information about the hypocenter. Do you know it? Let me tell you. The hypocenter is a creature from Greek mythology. It has upper body of a human and lower body of a horse. Used as a sample for Sagittarius zodiac sign. Now, back to pathology again. Do you remember your diagnosis? Squamous cell carcinoma? Unfortunately, squamous cell carcinoma was only the upper body of a hypocenter, which makes you think it is just a normal human being. However, in fact, there is another part. Other H&E slides showed different components. This slide showed two distinct Other H&E slides showed different components. This slide showed two distinct components, small round blue cell neoplasm, marked by blue arrow, and the squamous cell carcinoma component, separated from each other by fibrous septa, marked by pink arrow. Here we can see the blue malignant round cell component. This component showed tumor cells form irregular highly cellular groups, nests, and clusters. The tumor cells are very small and ovoid in shape. There are many mitotic and apoptotic bodies. The cytoplasm of the tumor cells are very scant. The nuclei are molded and very hyperchromatic, with absent nucleoli. No differentiation is seen. Areas of necrosis is seen in malignant blue round components. Here we can see squamous cell emboli in the round blue cell tumor components. Although different, can be said together as a collision tumor. A hypocenter, not a human. The challenge now is the diagnosis of small round blue cell components. Our differential diagnosis could be small cell carcinoma by morphology, scant cytoplasm, molded hyperchromatic nuclei, and inconspicuous or absent nucleoli. By immunophenotyping, CK positive, synaptophysin positive, and CD56 positive. Lymphoma by morphology, separate lymphocytes in a background of inflammatory cells. By immunophenotyping, LCA positive. Ewing sarcoma by immuno, CD99 positive. Merkel cell carcinoma by morphology, large cell hyperchromatic vesicular nuclei with prominent nucleoli. By immunophenotyping, CK20, synaptophysin, and CD56 are positive. Melanoma by immunophenotyping, positive S100 and positive HMP45. Let's move to our immunohistochemistry. Positive CD56, positive synaptophysin, positive CK, and negative S100, HMP45, CK20, and CD99. LCA is negative with internal positive control. So we can exclude lymphoma, Ewing sarcoma, Merkel cell carcinoma, and melanoma. So our final diagnosis was primary cutaneous collision tumor formed of a squamous cell carcinoma and a small cell carcinoma, although metastatic workup was recommended to rule out the possibility of skin metastasis, as cutaneous small cell carcinoma is very rare. Let's talk about collision tumor. Collision tumor is a neoplastic lesion composed of two or more distinct cell populations that maintain distinct border. It could be two benign tumors, a benign and malignant tumor, or two malignant tumors. The acceptable theories are coincidence, cancerization theory, that sought to appear in different cells of areas which undergo recurrent damage. Interaction theory at which one neoplasm produced epidermal or stromal changes that induced a second independent neoplasm to form through paracrine effects. Arousal of tumor from pluripotential stem cell with subsequent divergent differentiation. Those theories were mentioned as the exact pathologic mechanism remain unknown. Related to collision tumor, there is some definitions should be discussed. First is the definition of collision tumor, which was mentioned before. Second, combined tumor, which is a neoplasm composed of two distinct but intertwined populations of malignant cells. Third, colonization. This example of a melanoma in situ that permeate a basal cell carcinoma with the condition that the atypical melanocytes remain within the confines of the basal cell carcinoma. Finally, by phenotyping tumor, which is a tumor that arises from a common stem cell precursor that undergoes divergent differentiation with the two tumor population, demonstrating overlapping immunohistochemical and molecular properties. Now, collision tumor formed of squamous cell carcinoma and small cell carcinoma had been reported in esophagus, maxillary, sinus, and the larynx. Cutaneous small cell carcinoma and squamous cell carcinoma had been reported as a combined tumor in two case reports. The cutaneous small cell carcinoma Small cell carcinoma commonly originates from lungs. However, it can also arise from the extrapulmonary sites, which are esophagus, colon, bladder, cervix, larynx, and in head and neck region. Extrapulmonary small cell carcinoma is very rare, with an incidence of 0.1 to 0.4 per 100%. Only there are 4 case reports about cutaneous small cell carcinoma. The prognosis of this rare entity is so poor that long-term survival is usually non-expected. Take-home message. Good sampling during crossing from different heterogenic areas of the mass is important. It is crucial to examine all H and E slides carefully. Collision tumor diagnosis affect modalities of treatments according to components of tumor. There is a references, and thank you.
Thank you so much, Dr. Collision tumors are always interesting and
Yeah.
interesting to present and study. Thank you so much for your effort, and thanks for your supervisors and all other colleagues.
Thank you.
Now we